Hello, today I'm going to discuss case 67, Odell book, 4th edition. The summary of the case is about a 65-year-old man presents to you at your general practice complaining of sharp and discolored teeth. Identify the cause and plan appropriate management. So in this case we are asking for management, and there is an intraoral photo presenting heavily discolored teeth, anterior teeth and posterior teeth, mainly showing gingival recession and root discoloration. We are unsure if it is a kind of caries, active caries or not. The patient complains of discolored and very sharp lower front teeth with pieces breaking away, and there is no pain. Okay, he has only noted this in the last 3 months. Medically, the patient had radiotherapy and chemotherapy for squamous cell carcinoma of the left tonsil, followed by surgery to the neck. This treatment was completed 18 months ago, and he was a heavy smoker, but now he stopped and he reduced his alcohol intake, but he was drinking more in the past. The dental history: the patient was an irregular dental attender, only seeking care when in pain. Extraorally, the appearance of his neck shows that the left side of the patient has a kind of scar, for presenting the surgery. We can and what can be deduced from the site of the scar: this is a typical incision to perform a supramylohyoid neck dissection, giving access to lymph nodes in levels 2 and 3. The incision starts a centimeter below the level of the lower border of the mandible and is more vertical posteriorly to avoid damaging the marginal mandibular branch of the facial nerve. The intraoral examination: the intraoral appearance is show that the alveolar mucosa appears dry and matte and glazed, which means there is a kind of xerostomia. And the alveolar ridge appears matte. There is a small but less than normal amount of saliva in the floor of the mouth. There is caries, particularly at the cervical margin of most of the teeth. In addition, there is caries at the incisal edges of the lower incisors, and enamel has chipped here. So the sharpness or the roughness the patient is feeling is due to the incisal edges of enamel of the lower incisors has been chipped off. What features of intraoral examinations are particularly important in this patient? So what I do have to take care about: examine the whole mouth and the visible oropharynx for carcinoma and potentially malignant changes, because in 10% of squamous cell carcinoma the patient may have a new primary tumor, which we may be able to notice while we're doing dental examination. However, it's somehow difficult to appear in its early stages. So what is the diagnosis? The diagnosis in this case is a kind of radiation caries. The patient has a kind of rampant caries now because of radiation. This name is given to aggressive caries that occurs frequently after radiation to the head and neck. Here it shows the classic distribution of lesions at the incisal edges, the tips of cusps and the cervical margins. So a classic distribution of radiation caries is in the incisal edges, tips of cusps and cervical margin. And what is the significance of this diagnosis? The whole dentine may be affected, but the enamel shell remains largely intact and the pain isn't generally reported. Caries may become very extensive and go unnoticed until teeth fracture. What are the factors contributed to radiation carriers. Reduced quantity and buffering capacity of saliva caused by radiation effects on the salivary glands. Other contributory factors are high sugar diet, reduced oral clearance of sugars, poor oral hygiene, often compounded by limited mouth opening, and the sore mouth. Changes in the oral flora may be a factor. So there are a kind of contributing factors. Contributing factors may be several factors, mainly because of the reduction of salivary production. And due to the reduction in salivary production, we can see that any other factor can affect dentine and enamel in a very bad way. Why can the salivary gland not be protected during radiotherapy? Radiotherapy of the head and neck mainly. Use of ionizing radiation to treat disease, usually X-rays to treat cancer, also damages normal tissue because so many important and radiosensitive tissues lie in the head and neck region, particularly salivary glands, eye, spinal cord, and thyroid gland. Protecting them is difficult, and some compromise often has to be made between effective cancer treatment and its adverse effects. The full curative dose for most head and neck cancers is between 60 to 65 grays. 1 gray is the absorption of 1 joule of radiation energy per kilogram, but mild salivary gland damage can be detected after only 4 grays. So, and severe permanent damage occurs with doses above 30 gray to the gland. Some protection is provided by fractionation, delivering the total dose in small daily amounts or fractions, usually 2 gray each weekday for 6 weeks. Fractionation allows some recovery time between treatments, but thus reducing toxicity to normal tissue. However, if the salivary gland lie in the path of the beam as it passes from skin to cancer, fractionation offers insufficient protection, and complete dry mouth will occur during treatment with partial and slow recovery afterwards. There are many ways to decrease the effect of radiation on salivary gland. However, in most of the cases, we are trying to reduce the effect of what had happened on teeth. As a dentist, I mean. So if you have to be able to know the amount of radiation the patient is taking for treatment, and if it exceeds 30, it will cause a permanent damage of the glands. Even it has a kind of recovery after 6 or 7 weeks, it will be a partial recovery and not 100% recovery. The adverse effects of radiotherapy to the mouth: early stages, we may see xerostomia, oral mucositis, skin burns, oral infections, particularly candidiasis, and taste alteration. In long term, you may see xerostomia, trismus, radiation carriers, loss of periodontal attachment, and osteoradionecrosis. Generally, there is a kind of weight loss, fatigue, eating difficulty, swallowing difficulty, and speech difficulty because of the previous xerostomia and trismus and osteoradionecrosis. So, what are the other adverse effects of radiation to the mouth and adjacent area have this patient developed? This patient was lucky enough that there was just a reduction in his mouth opening, while there are kind of mucositis and xerostomia. Otherwise, he was pretty good. So what kind of investigation we have to do? First, the investigation, we have to take clinical and radiological examination. These are performed to assess the extent of caries, periodontal condition, and preapical disease, alveolar bone levels, and restorability. Oral care habits. Ask patients whether they are brushing their teeth and about their toothpaste use. Patients may stop brushing during the painful period of mucositis because this condition renders the mouth too sensitive to toothpaste. Ask about food intake. Many patients have difficulty eating during and after radiotherapy because of painful mucositis, taste changes, and dryness of the mouth, muscle fibrosis, and mucositis. What kind of treatment we can do? The ideal treatment would maintain the teeth with restorations and periodontal treatment, thus avoiding extraction or periodontal therapy. Why? Because once radiotherapy is done, we can't go for extraction or any surgical intervention to avoid osteoradio necrosis of the bone. And the ideal is the patient has to make a dental visit at least 2 weeks before radiotherapy, because if any treatment is going to be done, it has to be done at least 10 days before the first radiotherapy in order to allow for complete healing for any kind of surgery or extraction. And we have to be careful about osteoradio necrosis even we are going to make any kind of subgingival curettage in case of periodontal treatment. Once radiotherapy is done, we are going to make any kind of treatment as a conservative treatment, endo operative, maybe crown and bridge, but nothing to be extracted or nothing to be directly dealing with bone. And which teeth is going to be extracted prior to any radiotherapy? Any badly decayed teeth which can be restored, partially erupted wisdoms, and if there is any kind of deep pockets which exceeds 5 millimeters, it's better to extract the teeth which is suffering from these deep pockets. And if we are trying to manage the very broken down teeth in the radiation field, we have to go for root canal treatment, and decoronation of the teeth are preferable if the risk is high. Decoronation is just to remove the crown after endodontic treatment, because it's we can't restore this tooth. We are just trying to make the pain, no pain for the patient. We are trying to manage the case in a safe way. So we make a root canal treatment and obturation, then we remove the crown because it can't be restored. And we have to give a kind of preventive measures for this patient. These measures are using very soft toothbrush at first, because he will suffer from a kind of mucositis, and after a while we can, when the soreness reduced, we can use a medium toothbrush, and this toothbrush has to be used twice per day with a very high fluoride toothpaste, about 5,000 parts per million. And we have to advise the patient to discontinue any kind of sugary intakes, and may use a straw while taking any acidic beverages. We are assumed to refer the patient to an oral surgeon if there is something is complicated, and we have to advise the patient of the risk of osteoradio necrosis, and make a kind of and as a general practitioner, we have to ask the patient to make a kind of regular visits to the dental surgery every 6 months. And at the end, thank you for watching, and please don't forget to see the questionnaire about it's a kind of MC questions about this case. You will find it in the description box. Thank you and goodbye.